Dear Chairman, dear colleagues, thank you so much for this opportunity to share the results of our research on non-invasive glioma grading with deep learning. Gliomas are the most common intrinsic brain tumors, heterogeneous by histological and molecular subtypes and variable in survival prognosis. The diagnostic procedures in patients suspicious of brain tumor typically start with neuroimaging. There are plenty of brain scanning modalities, including MRI with contrast enhancement, tractography, perfusion, functional MRI, PET scanning, spectroscopy, relaximetry, etc. All the modalities are important for a neurosurgeon when deciding whether to operate patient or not and when preparing for tumor removal. But surgery is not the only treatment option. In many cases, it is followed by radio and chemotherapy. The key to choose the right treatment option or their combination is histological and molecular tissue verification with invasive biopsy either during a microsurgery, when tumor removal is absolutely indicated, or with minimally invasive stereotactic biopsy when tumor removal is questionable. The histological and molecular diagnosis determines the decision on choosing either radio or chemotherapy or microsurgical treatment, or their combination. Now just imagine for a second that you have a tool that can predict tissue type without invasive and risky procedures. In that imaginary situation, no bloody biopsy is needed. Is that possible? In our pilot study, we tried to push one step towards this dream goal on non-invasive diagnostics. We aimed to evaluate the quality of deep learning in subtyping gliomas based on preoperative magnetic resonance imaging. A widely used classification of brain tumors proposed by the World Health Organization in 2007 divides all gliomas into 4 levels: low grade, who grades 1 and 2, and high grade, who grades 3 and 4. This classification was revisited in 2016. The new system appeared more complex and relied on molecular subtypes associated with treatment outcomes. Despite the rationale behind the new classification, its application is costly and requires expensive analysis. That is the reason the old 4-level classification is still in use, especially in countries with limited resources. We started our pilot deep learning in glial tumors classification with this 4-level target. The technical task was to classify MRI data from patients with glial brain tumors into 4 grades with machine learning. We used preoperative MRI from patients with gliomas anticipating tumor removal. The data were obtained from Image Archive at Burdenko Neurosurgery Center for a period between 2009 and 2018. We used T1 axial images with contrast enhancement in DICOM format. To accomplish our research goal, 2 basic approaches were proposed. The first one, a 2D classification, was a prediction of tumor type for each brain slice independently. The second approach, a 3D classification, predicted tumor type for the complete set of brain slices from one study as a single object. The images were preprocessed differently in each approach. In 2D case, all images were adjusted to one size with scaling and augmentation techniques. In 3D approach, the number of slices in each 3-dimensional object was set to 32 with image normalization. The training dataset was kept as 80% of the original. Both the validation and testing samples were 10% of the initial data. ResNest 200E deep learning architecture was trained on 2D images. In the 3D approach, we applied a DenseNet neural network. Atom optimizer and cross-entropy as loss function were used in both cases. We tried 2 types of target variables for every approach. One way was a binary split of a target variable into low-grade and high-grade classes. The second type was a 4-level target variable corresponding to who grades. We did all the calculations in our supercomputer infrastructure. Here comes the number of objects we dealt with in 2D and 3D cases. A total of 707 MRI studies were obtained, providing almost 18,000 plain images. Here on the slide, you see the distributions of the 4-level target and the corresponding binary variable. You may observe the initial balance between classes. Now let's turn to machine learning performance. Discriminating between two classes didn't show brilliant results over the two approaches. Most metrics were better in the 3D case except for specificity. The results of the 4-level classification are a bit different. In the 2D approach, the metrics were not that impressive. In contrast, the 3D case showed good quality in the 1st and 4th grades detection and was less accurate for the 2nd and 3rd grades, reflecting the difficulties a doctor has when suggesting diagnosis by MRI. Finally, the overall quality of DenseNet solution with 3D objects appeared to be better compared to ResNest model trained on distinct images. The related research on the topic shows promising results which are consistent with the output of our pilot study. For instance, Chaw and co-authors showed good high and low glioma subtyping based on radiomics and shallow learning. Sinnerer and co-authors demonstrated high performance of convolutional neural networks used with wavelet radiomics features in discriminating gliomas grades 2 and 3. And a range of studies presented in a recent meta-analysis by Jian and colleagues shows the potential of machine learning to predict genomic mutations for glial brain tumors based on MRI. I represent Burdenko Neurosurgery Center, which is the biggest neurosurgical facility in Russia and one of the biggest in the world. You see the amount of data we collect due to our surgical activity. That is the reason we could obtain quite a substantial MRI dataset for the study, which is a typical limiting factor in that type of medical research. So we hope to continue on this project and process much more data in our experiments. We also believe that combining images with other data sources in neurosurgery may contribute to better solutions in non-invasive diagnostics. So, what is the rationale for using advanced image analysis with machine learning in glioma diagnostics? At the very beginning of my talk, I fantasized about non-invasive glioma tissue diagnostics, but that is a dream goal today. What is much more pragmatic from a short-term perspective is gaining more valuable information from neuroimaging with feature engineering and machine learning, and that is a realistic goal. Given some promising results in our pilot research and data from colleagues, we advocate for using artificial intelligence in glioma imaging. We hope that in the future, these technologies will help to simplify diagnostic procedures, increase safety, personalize care, and shorten the time from the disease manifestation to the best treatment administration. If we substitute some of the expensive technologies to digital, if we take some work burden off the doctor, this also leads to cost savings. An increase in neuroimaging informativeness is a crucial goal itself. And yes, we dare to fantasize today, but nobody knows where it leads us tomorrow. So we conclude that deep learning is promising in non-invasive glioma subtyping using magnetic resonance imaging. I would like to thank my colleagues from Laboratory of Biomedical Informatics and Artificial Intelligence and the team from Lomonosov Moscow State University for all deep learning work. Thank you so much for your attention.